how to gain surgical expertise in that? So I told them in the beginning that good knowledge of anatomy is mandatory. So how to learn? So the cadaver dissection is also required so that you become expert in handling the most of the structure, because only then you will come to know that what is where. So what you are going to expect during surgery. So that is important. So otherwise maybe how to brush up your techniques. So fellowship program, maybe working with some senior colleague is likely to help you out. So this is a case of cadaver dissection. I tell you that in most of the cadaver dissection which are happening in the country, so you need to attend them hands-on. You have to go and dissect the cavernous sinus, and otherwise it's not difficult to learn. So this is a video of cavernous sinus dissection. Right? So I can tell you that on this side is the temporal and this side is frontal side. This is the orbito-frontal band, orbit, right? Meningo-orbital band is being cut. So this is the temporal base, and lot of bony protuberance are there, so which we need to drill up. So actually the craniotomy is a frontotemporal craniotomy and zygomatic osteotomy. Most of the time, in majority, I would say that more than 90% exposures, I don't require any orbitozygomatic osteotomy. Just zygomatic osteotomy and pulling the temporalis muscle down is more than enough. And then you have to flush the base of the temporal so that you are actually into absolutely vertically, you are drilling it then and making it into your direct vision. So this is the coagulation of few of the bleeders, and this middle meningeal artery need to be first dissected and cut. This is the drilling of the superior orbital fissure. So that this will expose the little bit part of your orbital area, periorbita, and orbital zygomatic osteotomy is not required. So this is the V2 division of, on the right side of the drill, this is the V2 division. So the nerves are V2, this is the drilling over the V3 so that it is clearly in line. So we have now visualized V2, V3, and now just posteriorly there will be the middle meningeal artery which will be dissected and cut first. Right? So this is V3, V2 is anterior, and this is the middle meningeal artery. We are now coagulating and cutting. So after cutting the middle meningeal artery, now you have to develop a plane. Usually I start anteriorly with the orbital, periorbita and the dura, because they are joining and there is always a groove there. You just have to have a sharp dissection from there, and there is a very good plane of cleavage with that. You have to develop that plane and keep on dissecting posteriorly. And here it is, I can see that, you can see that this is V2, this is V3. So this is actually cavernous sinus tumor, and you just have to keep on peeling off this one layer of the dura over the cavernous sinus lateral wall, and it is not difficult. You just have to keep on sharp and blunt dissection, both is required, and going posteriorly, and here it is V3. This is a dissection of the V3 and just lifting the dura off the V3. So these are the fibers of the V3. Overlying it is just the dural margins. So once your dissection is going on over the V3, you will always see that a little bit of CSF starts coming out from there, because there the CSF crevices are there from the Gasserian ganglion, which is actually very prominent over the V3 division of the fifth nerve. And usually the venous bleeding is there, but it is not very challenging. So if you remain into that correct plane, now you see that these are all the V3, V1 divisions, the nerve rootlets are there. and going medially. This is the lateral, this is the medial part. This actually, I will show you later that this area is actually third nerve is stretched over the tumor. Yeah, now this is the anterior cleanout process. So the cavernous sinus lateral wall dissection is almost complete. Now we'll drill the anterior cleanout process. So the cleanotectomy is done. Now because it is clearly visible, it is hardly a job. It can be done very quickly with the help of your pneumatic drill. So it is done. So this is actually, this nerve is third nerve which is stretched out here. This is the area. And just medial to that there is optic nerve. So this is just clearing the little bit of bone over the optic canal. So now you see that the whole of the temporal lobe is lifted off the cavernous sinus, right? This is optic nerve with the sheath, and this is the third nerve which is stretched out very clearly, and this whole tumor is in the cavernous sinus. Now you see that everything is extradural. Now you have to develop the plane between the rootlets of the nerve fibers of V1 here. So you can just longitudinally dissect from here and enter into the cavernous sinus. And many times with the benign tumors, be it a schwannoma or it is a cavernous sinus meningioma, in both of these conditions the internal carotid artery is pushed anteriorly and inferiorly. It is never posteriorly. In cases of pituitary adenoma, it is encircled, and many times in cases of the meningiomas also, it is encircled all around. So that way you have to correlate with your radiology that where you are going to find it. So by and large, this is the picture in most of your cavernous sinus dissection. Once you have achieved this much of dissection, so removing tumor or any pathology from the cavernous sinus is not difficult. So this is a case of cavernous sinus meningioma, which is actually encasing the internal carotid artery. Actually, this is inside the cavernous sinus, which is usually is very uncommon. So internal carotid artery in cases of meningioma is usually shifted anteriorly and inferiorly, but this was quite unusual. And with the same sort of dissection, we went in, lifted, elevated the whole of the cavernous sinus. This is the V3 division. CSF is coming. Then once you have dissected it all around, so then you start coagulating. Once you start coagulating, and then the tumor starts shrinking also. So whatever the bleeding is there, usually it is venous in origin and can be easily controlled. So you see that. So once you are coagulating and the tumor is clearly becoming more pliable, more manipulable. Yeah, now you see that it has lost its turgidity as we are coagulating more and more. So now the only thing is that we have to find out where is the internal carotid artery, and you just have to go toward the foramen, foramen lacerum, and you see there. So now you see that I have seen that this is the internal carotid artery which is there. I have found the one end there. So now I was confident that it is okay. I have seen it. I have started cutting because it was encircling it. I have to cut it. But something happened here. Sorry. So there was one branch of the cover that is actually one of the meningeal branch was there, which actually got cut very close to the ICA, and just applied the clip and continued that. So ICA per se is not clipped, but just you see that a lot of branches coming out of the ICA here, so which individually caught and cut. So same way that 360-degree dissection around the ICA is done. So once everything, the tumor is taken off, it is trapped, and these branch holes are actually just clipped with, repaired with just 2 sutures of 7-O-proline. This is another case of cavernous sinus meningioma. So the same approach, same dissection. And same dissection from the cavernous sinus lateral wall from the temporal lobe. And once it is done, this tumor is actually extending into the sellar. You see that this whole tumor is extending into the sellar. So this patient actually presented with visual deficit on the right side. So that was the reason for choosing this patient for surgical therapy. So once you are just coagulating all around, so it loses its turgidity. So the lateral component from the cavernous sinus is now almost dissection is done. It is taken off. Now there is the intrasellar component. So ICA is actually interiorly somewhat here. Okay, the cavernous sinus component is gone. Now it is the intrasellar component. So because the ICA is anteriorly pushed, so actually I have seen it. It is somewhat here. So again, we are just looking around from the plane of cleavage from there. So whatever the components are there, maybe bits and pieces, they are taken off, and whatever the venous bleeding is there, either we use the flow seal or maybe a tissue glue. So this is the PCOM. You see that this is the PCOM which is coming out of the ICA, which is now divided. So because it was not very robust, and then entering into the sellar. So the same way, just dissect around it and it will come in one single piece. So the base is actually just filled up with that fat and glue and just come out of that scenario. So this is a Peter-Sapers chondrosarcoma, the same approach, and now you see that we are just dissecting from there, and it is there into the one of the, it is, see, the jelly type material is coming there, usually very soft, but in between there are components of bone also. So which have very sharp picues. You should not be very manipulative there. So if you are manipulating there, sometimes that sharp edges can injure the ICA. So very carefully you have to just take them out. So venous bleed is always there, but these are not very challenging. With the help of your gel form or with the help of your cotton, they can very easily be controlled. So, but the USP of this thing is that you need to be very widely dissecting the cavernous sinus. Once that everything is in front of you, the chances of complications are not there because you are under full control. So this is a cavernous sinus bleeding, and it is controlled with the help of a gel form and then a patty. Just press over time and it will stop. So this tumor is completely out. This is a venous blood again, and because one of the spot is there with the lateral wall of cavernous sinus is disrupted, so just again controlling with the gel form. So that's all. So once it is controlled, and just put a little bit of glue to support that, and our surgery is over. So this case I would like to discuss. So this is a case of intractable trigeminal neuralgia, and there is a very small Peter's apex meningioma which is going into the macral scale. The patient was having intractable pain, and he was initially treated with gamma knife. So patient was given gamma knife, and the usual dose for the meningioma is 12 to 14 gray. So thing is that this much of the dose is given, and the tumor has actually shrunk in size. but his pain never disappeared. The patient was so debilitated in pain that he required that something has to be done. But problem with that next dose of gamma knife for trigeminal neuralgia, which is actually around 85 to 90 gray of the radiation dose, point dose, which we have to deliver. But for that you need to see the nerve itself, because this nerve is obscured by the tumor. We cannot know that where to give that much of dose so that the patient is relieved of his pain. So ultimately we convince the patient that probably we have to take the tumor out only then. Now how to take this tumor out? So we can go retrosegment also, but problem is that we can only take this part of the tumor, not into the cavernous sinus, which probably may be the reason of the patient's pain, because the nerve is still not decompressed. So again, then we went ahead with it subtemporal cavernous transcavernous approach, so that we open up the posterior part of the cavernous sinus and take this tumor out from there, and tumor as a whole. So this is the tumor which is very subtly entering into the Meckel's cave. Very small tumor. So again, posterior part of the cavernous sinus dissected completely. This is V3 fibers, and now we are drilling this Cavernous triangle also. So Cavernous triangle is drilled, and then we just cut that. This is the petrous dura in the posterior fossa, release the CSF, and now we are just cutting the base of the temporal dura and entering into intradural compartment, and then cutting the tentorium from lateral to medial side. So this is the lateral edge of the tentorium. So we will be cutting, this is the floor of the temporal fossa, a very small incision here. So now you said this is all the posterior part of the cavernous sinus. V3 division, this is the V2 division fibers. So the tentorium is cut from lateral to medial. Now you see that once the tentorium is completely cut from lateral to medial, the tumor is coming into picture. So this is the tumor, and here it is the fourth nerve. Here this thin white structure is fourth nerve, which we have to preserve. So now you see that the tumor is partly decompressed here, now entering into the cavernous sinus, just opening the cavernous sinus along the fibers of the fifth nerve. So mind it that this is a post-radiation. Many times you feel that once the radiation is given, the tumor becomes difficult to dissect and all that. So probably this is not the case. This whole tumor will come as a single piece. Just opening it up. This is the tumor into the Meckel's cave. Now you see that this whole tumor is coming out in one piece, and the fibers of the fifth nerve are completely preserved. It's a very good plane of cleavage. So you can just dissect it out completely. This is the area of the Meckel's cave. So this is the whole fibers of the fifth nerve. It's completely decompressed from its origin from the brainstem till its destination to the foramen ovale and the foramen of rotundum. So this whole nerve is decompressed. The tumor is completely taken off. So this is the fourth nerve again. So tumor is being dissected, and this is the just prenatal component of the meningioma. And now the tumor is completely out, and the nerve is just seen that if there is any vascular loop in and around the fifth nerve, that also can be decompressed, so that there should not be any vascular loop, which may be the reason for the patient's neuralgia. So that is also taken care of. There was nothing significant vascular loop there. So that is the surgery. So this is again another scenario. The tumors which are not there into the cavernous sinus, but they are actually approached through the cavernous sinus. So again the same approach, we lift the temporal lobe, because many times the interpedicular cavernous craniopharyngiomas, other interpeduncular tumors, which are sometimes the basilar tip apex aneurysms. So they require a very good exposure, wide exposure, so that you can manipulate your instrument there, you can manipulate your clips there, so that you need a good exposure. So there is no brain retraction, and at the same time there is no brain sacrifices there. For example, in this case, you just lift the whole of the temporal lobe along with its dura of the cavernous sinus, bring it back around more than 5 centimeters from the temporal tip, so that much of space is there. Once the CSF is drained, temporal dura is lifted from the cavernous sinus, the very wide space is there. So once that is achieved, so you can have a very good exposure. So this is just a dissection of the cavernous sinus, same way we have done before. So now what we have to do here is that, so usual curvilinear incision in the frontotemporal like pterional, we do it that. After that we give a T incision from the middle part of the along the salient fissure till the anterior clean out process, so that we separate the frontal lobe from the temporal, so that this is the T junction incision, so that the temporal lobe is separated and it is lifted along with this dura posteriorly. You see that this is the one leaf of the anterior part of the dura. Now this dural separation will continue posteriorly till we feel that it is enough for us. So after that we got a lot of corridor from the lateral aspect. We open the salient fissure completely from top to bottom, so that the temporal lobe goes back as a one unit. There is no retraction on the veins or the brain parenchyma. Once that is done, so we just see that internal carotid artery, now this much of corridor which is available. So I would like to now, sorry, what's happening? So, okay. So thing is that you see that there is a posterior communicating artery. This very thinned out vessel is there, and it doesn't have any perforator on it. So this vessel we can easily sacrifice, and so that it again gives a very wide exposure. Our internal carotid artery can be manipulated superiorly and medially, and we have got a so once that is done, so the tumor cyst is decompressed, tumor is dissected all around. You will see the basilar artery, PCA into picture. These are the basilar tip, we can easily see. And this is the part which is actually going into the cavern, third ventricle from below, interpeduncular cistern. So it is just pulled down. We are in control of basilar tip. We are having the bilateral PCA vision. We have ICA vision. We have the third nerve on the ipsilateral vision. And under the tumor, we can see the third nerve also on the opposite side. Now we are going superiorly to find that pituitary stalk. Actually, this pituitary stalk was completely replaced by the tumor. I tried to dissect it off. Then I find that it is practically, there is no pituitary stalk which is connecting the pituitary gland to the hypothalamus. So it was all replaced by the tumor. So I purposely just sacrificed so that I can achieve the complete tumor excision here. So patient had chronic DI before also, and it worsened a little bit post-operatively, but we could manage with all sort of medical therapy, and that was not a big task for this particular patient. So this whole tumor is coming out. So now see that this is such a big corridor, lateral and inferior to the internal carotid artery, and there is no manipulations or dissection or in and around the optic nerve or the optic chiasm. So the tumor is taken out with this corridor, and there is no brain retraction is required frontal lobe. The only thing is that temporal lobe is taken back along with its dura, and it didn't have any problem. So this is again same thing was peduncular, thalmopeduncular astrocytoma, same approach and same dissection, and again the thin posterior communicating artery, which is again divided and it is separated. So make sure that you are not compromising any of the perforator arising from the posterior communicating. You have to make sure that they are preserved. So once that is there, so this whole tumor basically becomes evident in front of you and a good plane of cleavage. Otherwise, this area is not easy to dissect from any other approach except this one. So complete tumor excision, this was actually a pilocytic astrocytoma. This is again a superior cerebellar artery aneurysm. Now this is a vascular surgery through the cavernous sinus, same approach. So this is the third nerve, which actually we are just dissecting it off. This whole area is basically the lateral wall of the cavernous sinus. So this is the aneurysm. So to get a proximal control, very thin wall, maybe around a few millimeters of aneurysm, so around 6 to 7 millimeters. So now because we don't have access to the basilar trunk as a proximal control in case of any eventuality, so we are actually lengthening the third nerve. This is the cistern of the third nerve. This is the canal through which the third nerve passes through the lateral wall of the cavernous sinus. It is opened up so that we have the ability to manipulate or medializing the third nerve. So we are just extending it further. So once the third nerve is mobilized a little bit further, so we have got a control to the proximal part of the upper part of the basilar artery. So appropriate lengthening is done so that we can manipulate. Once that is done, so maybe a temporary proximal flipping of the basilar trunk is done, and this is the aneurysm. This is superior cerebellar artery. This is PCA. This is PCA. A temporary clip has now already been placed. It is just behind that, and this corridor gives the best approach for this aneurysm. So this is a temporary clip to the basilar artery. This was taken out. So otherwise, this aneurysm we may have to get a half and half approach, maybe subtemporal. Sometimes these are very difficult to approach from Kawasai's triangle. So this becomes direct. So if we have a difficulty in reaching down to the basilar trunk, what we can do is that this is the area of the posterior clean out process. We can drill out this much of bone. Now we know that this is the third nerve. We can medialize or lateralize depending upon your surgical corridor and approach. We can drill it out with the help of your pneumatic drill, but I would recommend that the bone Cusa is a better tool, so that it doesn't move, only that it vibrates and shells off the posterior clean out very nicely without any much of the fuss, and you can go down till the basilar trunk. Same giant multi-compartmental pituitary adenoma operated with the same approach. A cavernous sinus hyalinized fibroma. So this is a radiological picture and approached through there, and patient doesn't have any cranial neuropathies. So left fifth nerve schwannomas, which is giant multi-compartmental, which is going actually extracranially also along the V3 division. So again approached from above, and we could take out the whole tumor from above. Patient didn't require any mandibulectomy or other neck approaches for that lower component, because we widely opened up the skull base on the temporal base, and we could deliver this whole tumor through above only. So to conclude my talk here, that the cavernous sinus approach, I would say that it is not difficult, but you need a full exposure of the cavernous sinus, and it yield excellent result with minimal brain interaction. Though it can, one can handle the middle fossa, posterior fossa, upper clivus at the same time. So excellent outcome. Sometimes we feel that these are inoperable or difficult tumors. Thank you.